Okay, let's begin now. Okay, let's begin from the first case I met. The first confirmed case is my obstetric patient. I did the routine obstetric examination for her since her gestation began from 2019. I did the last obstetric examination for her on January 20, and she decided to deliver the baby by cesarean because she got her first baby by cesarean operation 3 years ago. She was admitted into the hospital on January 22, and the laboratory examination results were all normal, including the blood cell count, the hepatorenal function exam, and the coagulation function exam. The operation was successful. Everything's okay, but the patient complained discomfortable that night, about 10 hours after the operation finished. She felt sick and her temperature was 38 at that time. Her CT scan was done right away, and the result showed typically ground glass change in her lung. Pointing just here, like the arrow show, and the nucleic acid of converted, we tested, but it kept negative until February 6th. And this time, the nucleic acid result is positive for the COVID-19. That was the third time for us to do the nucleic acid examination for her. And that time the result confirmed that this is a confirmed patient. The patient was isolated soon after she felt fever and sick, and the CT positive result come out, and her baby was taken home at once. It was lucky that this patient was a mild patient, and she recovered quickly after she complained with the fever for 4 days later. And you can see here at the February 4th, the lesion in the Feng has disappeared, almost disappeared. And here we cannot find any lesion in her left lung anymore. And this patient was discharged from the hospital on February 20 and was sent to the isolation hotel to be under the medical observation for another 14 days. And this is the first case. And here is the second case. The second case I want to share you is a patient. She is a 32-year-old primipara, and she came to see me on February 2. At that time, she was at the gestation of 41 weeks. 4 days before she came to see me, she was caught by the cough, fatigue, and fever after she and her husband took a taxi. She presented fever first, and 2 days later, her husband also presented a fever. But her husband felt better than the patient, the mommy. When they came to our hospital, we did the nucleic acid and CT scan for them right now. And the CT showed typical changes for 2 of the couple. Look at the arrow here. And this is the pregnant woman's result. Here is the right lung. We can see here, this is the lesion. And here, for the left lung, a lesion is obviously here. The patient was admitted into the isolated ward at 1 a.m. on February 3. And she got the cesarean operation at 6 p.m. that day because of the persistent fever and no tendency of contraction of the uterus. Her baby was admitted into the NICU because none of the couple could take care of the baby. After the mother finished her operation, the husband was also admitted into another hospital to get the therapy of COVID-19. Also, the lucky thing happened with them that the mother was a mild patient too, and she recovered quickly. We can see here, and this is the image her husband was taken on February 2. And after the CT scan, the next day, he was also admitted into another hospital. These three images show the disease course of the mother from February 7, February 12, and February 8. You can check the lesion in the left lung. It becomes smaller, and here almost disappear. So, and this, I want to show you that this is also a very lucky couple. They get healthy baby and they all recover quickly. In this, the third case. The third case I want to show you is multipartum. Before she came to the fever clinic of our hospital, she has been accompanied by the cough for 10 days, while she did not present fever. As soon as she arrived at the fever clinic, she was arranged to get the nucleic acid and the CT exam. Both of the exams showed positive results, and she was admitted into an isolation ward too. Until on February 9, the labor began spontaneously from 8 p.m. and a healthy baby came out on 26 past 10 o'clock that night. Similar with the other two pregnant patients, she was also a mild patient and she recovered also quickly. And this image is taken on February 5, and here on February 20, the lesion almost disappeared. She was discharged from the hospital on February 28. From the three cases, I would like to share with all of you that COVID-19 is a challenge for all of us from the January of 2000 until the end of March. There are totally 7 trial editions of the guideline about the diagnosis and treatment schemes for COVID-19 published by the National Health Commission of the People's Republic of China. And the 5th trial was published during the peak time of coronavirus transmission in Wuhan, almost at the beginning of February. The trial of the final trial of addition pointed out that a patient might be diagnosed as suspected or confirmed case based on the result of the epidemiology history, the clinical manifestation, and the etiology examination result. And the doctor at that time could make a COVID-19 diagnosis for a patient in Hubei province, just with the typical CT change and the clinical manifestation, while without the positive nucleic acid result. It was called clinical diagnosis. Moreover, the 5th edition proposed that asymptomatic patients could spread the virus. At that time, the 5th edition promoted that all patients in Hubei province could get help from the healthcare workers. But now we use the 7th trial of addition. This trial of addition was based on the result of autopsy. According to this trial, IgG and IgM result was added to the diagnosis basis. Here I show you in the 7th trial edition, what is the meaning of suspected cases? According to the 7th trial edition, when we talk about the suspected cases, we should focus two things: the epidemiology history and the clinical manifestation. About the epidemiology history, 3 things should be focused. The first one is the traveler history or resident history in Wuhan or surrounding areas near Wuhan or other countries with cases reports within 14 days before the onset of the illness. This is the first thing. And the second thing about the epidemiology history is the contacted history with patients infected with COVID-19 within 14 days before the onset of illness, or the contact history with patients who had a fever or patient with respiratory symptoms from Wuhan or surrounding areas near Wuhan, or from countries with case reports within 14 days before the onset of the illness. And the 2 things we can call it contact history. And the third thing about the epidemiology history we should focus is about the clustering occurrence. Except the academic history, we also should pay attention to the clinical manifestation. About the clinical manifestation, there are also 3 important things to be paid attention. The first is the fever or respiratory symptom, like cough or something. The second one is the reduction in the total number of leukocytes, or normal in the early stage of the stage, or the lymphocyte count is reduced. This is a great change for coronavirus patients. The third one is about the imaging characteristics. The typical CT change in coronavirus-19 patients showed the ground glass-like image. And if a patient is confident with at least one of the epidemiology history or one of the clinical manifestation, or a patient is confident with at least 2 of the manifestation, we will make a diagnosis for this patient that she's a suspected case. If a patient was a suspected case, we will do the etiology examination for her. And here is the confirmed case criteria. The confirmed case signifies clinical diagnosed or suspected case with one of the following pathogenic evidence. The first one is the real-time PCR or respiratory specimens or blood specimens is positive for the detection of coronavirus-19 nucleic acid. The second is the virus or the viral gene sequencing is highly homogeneous to coronavirus. And the third is the IgM or IgG of coronavirus is positive. IgG is changed from negative to positive, or IgG in the recovery period was more than 4 times higher than in the acute period. These 2 have the meaning for us to make a diagnosis. According to the diagnosis, when we meet a pregnant during the transmission of coronavirus, I think all of the pregnant women around the clinic should get carefully screening, includes the epidemiology history and the clinical manifestation, especially the cough, the fatigue, and the fever. Sometimes blood cell count should be made. For the suspected case, etiology examination is necessary. For the confirmed case, the patient should be sent to the designated hospital, and if labor was required, the patient should be sent to the isolated operating room, and the mode of the delivery should be decided at that time based on the obstetric condition at that time. The multidisciplinary assistance is provided by the Department of Neonatology, Anesthesiology, Respiratory, and Obstetricians. In addition, when pregnant women plan to be admitted into the hospital, our doctors would advise her to confirm the only one of the companion family member who will accompany her during the whole duration of hospitalization, and will always advise the companion receive the thoroughly screening just like the mommy. In this way, totally 442 pregnant women finished the delivery in Tongji Hospital from January to March, and totally 379 babies were discharged from the obstetric department with their mummy successfully. For the 442 patients, 21 of them were confirmed cases, and another 21 of them were suspected cases. This is the data of my hospital. And the best thing is that none of the doctor or the nurse was affected by the coronavirus in the process in my department. And none of the patients and their companions was affected by the coronavirus-19 in the process either. For all of the confirmed cases, the patients recovered thoroughly. None of the baby was affected by the coronavirus-19. We also summarized the clinical characteristic of 7 confirmed cases, and we published it in the Lancet Infection Disease. It seemed that the clinical characteristic of this patient with coronavirus-19 during pregnancy was similar to those of non-pregnant adults with coronavirus-19 that have been reported in the literature. The maternal, the fetal, and the neonatal outcomes of the patient who are infected in late pregnancy appeared very good, and these outcomes were achieved with intensive active management that might be the best practice in the evidence of more robust data. And we also, in addition, we also try to explore the problem of the intrauterine vertical transmission of the coronavirus-19. We find nucleic acid negative in the amniotic fluid from 2 pregnant women who were diagnosed with coronavirus-19 in the early stage of pregnancy. We get the amniotic fluid at the gestation of 16 gestation. But from our opinion, although coronavirus was not detected in the amniotic fluid of these 2 patients, the possibility of vertical transmission in early or middle pregnancy would not be ruled out for several reasons. The reasons are many. For example, the stability of the RNA virus might affect the rate of positive. This is one. And another, the case we detected only 2. Maybe larger prospective study and more data are needed for the for reliable conclusion. Here I want to show you some image record. This image was taken during the past 3 months. And thanks for everyone participating in the labor process. A success labor come from the joint cooperation, include our patient. They also struggle with the doctor and the midwife. I think at last I want to show you a picture I taken on April 8th. At that day, Wuhan was reopened, and in that morning, I found a morning exercise downstairs. It's the first time for me to find a morning exercise appear in my house estate since Wuhan was blocked on January. So I think if everyone struggles with the coronavirus, I'm sure help is right ahead. I wish all of us will be okay. Okay, that is my lecture. Thank you.
Thank you, Dr. Liu Haiyi. Our next speaker is Dr. Rong Zhihui. Dr. Rong Zhihui is an attending neonatologist working in the neonatal ICU and has participated in the management of neonates born to mothers with COVID-19 since early January 2020. Let's welcome Dr. Rong Zhihui.
Thank you. Thank you, Teal. And good day, friends from all over the world. My presentation today is
查看选项。不，你先共享，你先共享。
Everyone, you can turn on your video so that we can see your face. It would be great to see everyone's face. Okay, you can turn on your video.
I'm taking a picture.
龙德惠，你先共享屏幕，然后在上面最上面一排的右侧方就有一个。
Everyone, you can turn on your video. Right now we have
我觉得我在共享
20 people
呀，
on
难道没有吗？
the video.
我在共享。
共享屏幕在下，已经在共享了。共享以后你查看下面，我看到了，我已经看到了。然后
在哪里？
奇怪了。
Disable
顶排。
哦，也是。
顶排最上面一排。
Yeah, I see Dr. Maza from Ireland already.
呀，不对呀，那我自己也打不开了呀。
不然你就不管它好，你直接就打好。
Ethiopia.
天哪！
智慧，你就直接开始好了。
我打不开呀，现在怎么搞的？
那就不管它了，直接弄了。
你就这样讲了，我们看得很清楚啊。OK， 直接上。对 ，OK， 好了。
开了。
Okay. So today my presentation is about the maternal-infant vertical transmission, and the main contents for this presentation includes the evidence that we already know about the vertical transmission, and also we will discuss what do we need to explore in the future. Oh, and this is me. I'm a neonatologist from Tongji Hospital. And this is our boss, Dr. Chen, and she participated in the creation of the guidelines of diagnosis and treatment of COVID-19 in neonates in China. I will start from the evidence that we already know. So this paper was published recently in Frontier Medicine, which was written by our team. And in this paper, we summarized 19 neonates born to mothers with COVID-19 from January 31st to February 29th. Altogether, there are 19 neonates admitted to our NICU. And the result is the time between the mother's onset of symptoms to delivery is from 8 hours to 21 days. And all the 19 mothers, they didn't receive any prenatal steroid because all the neonates are term or near-term babies. And 6 out of 19 neonates, 19 mothers received antivirus medication, and most of them are Chinese traditional medicine. And all the delivery occurred in a negative pressure isolation room. Neonates were immediately separated from their mother and transferred to NICU. There are altogether 13 male and 6 female infants included, and the average gestational age is around 39 weeks, and average birth weight is around 3,300 grams. So very fortunately, none of the neonates needs any respiratory support in the NICU, and none of the neonates developed any clinical, radiologic, or hematologic biochemical evidence of COVID-19. And here I also share with you one of our preliminary data of the laboratory test of the neonates born to confirmed COVID-19 mother, clinical diagnosed COVID-19 mother, and also control mothers. We can see from this table that the lab result have no difference, including the total white blood cell, lymphocytes, neutrophil, hemoglobin, platelet, C-reactive protein, and the liver function, as there's no difference between the 3 groups. So when we talk about the mother-infant infection, there's 3, we can subdivide it into 3 points. The first one is the intrauterine vertical transmission, and the second one is the infection, the baby infection during the delivery, mostly are from contaminant with the maternal blood or secretion. And the third one is the neonate infection postnatally, especially during breastfeeding and closely contact with infected patients or caregivers. Let's talk about the first one, the intrauterine vertical transmission. According to the literature we can find from the PubMed, it shows that the angiotensin converting enzyme 2 receptor have very low expression in the placenta. And also, one article published in the Chinese Journal of Pathology showed that the pathology of placenta of an infected mother lacked the morphological changes related to the virus infection, and the SARS-CoV-2 nucleic acid in the placenta was undetectable. All these facts indicate that the intrauterine vertical transmission during the late pregnancy is likely impossible. However, it remains unclear if the maternal viral charge or timing of the SARS-CoV-2 infection may influence the transmission. We can find one of the papers published yesterday. They present a case of a miscarriage abortion during 2nd trimester in a woman with COVID-19. And the author thinks that the miscarriage is because of the SARS-CoV-2, supported by the virology findings in the placenta, may indicate that the virus can cross the placenta barrier. although there's no evidence, still there are lack of evidence of vertical transmission, but absence of the virus is not surprising given the stages of the fetal development and the short time of maternal infection. So when we retrieve the vertical transmission from the PubMed,
卢医生，你可以把那个disable 一下，有人在画了2根线。
我就是不知道 disable 在哪里。
最上面一排。
OK。
查看。
OK。So we can find at least 4 papers and published. Yeah. 我的共享。
整个录像都有。
把我的共享关掉了。哦。4 papers they present early onset of SARS-CoV-2 infection in neonates. And the first paper was published by Dr. Wu to show that they find a neonate's throat swab PCR positive at 36 hours of age. And the second was published by Dr. Zheng. Then he investigated 33 neonates born to mothers with COVID-19. And he found that 3 out of 33 neonates, they find the virus PCR positive on day 2 and day 4 and turn to negative on day 6 and 7. So it's a transient positive PCR from the neonates. And the last 2 articles is about antibodies. So what's the diagnosis for the neonates with SARS-CoV-2 infection? And we think the SARS-CoV-2 PCR is the golden standard. So according to the literature, and most of the mothers from the mother's placenta, umbilical cord sample, and amniotic fluid, breast milk, all the PCR is negative, except the 19 weeks, the miscarriage placenta. And for neonates, and the sample from the gastric lavage from the neonates right after birth, and the urine blood sample from the babies are all negative. And 2 or 3 papers show the throat swabs and the feces PCR is positive, but it's a transient, positive only for a very short time. And when we find one of the article published in Intermediate Medicine, it shows the characteristics of pediatric COVID-19 infection. And the author found that the SARS-CoV-2 PCR in the feces in the children could be remained positive for months. So it's quite different from the neonates. Whether the only once positive in the neonates is just a transient positive, why it not prolonged for months, still give us a lot of questions to investigate. For the antibodies, and this figure is from from New England Medicine, published on 2003. It shows the specific antibodies of IgG and IgM in the infected patients. We can see the IgM increase at the end of the first week after infected with the virus, and increase to peak level is around 3 weeks after infection, and then decrease gradually. With the decrease of IgM, we can see the IgG increase. But so this is the first intrauterine vertical transmission, and for the second, for the infant infected during delivery, in our hospital we followed the following 4 rules. First, all the delivery was occurred in an isolated operating room. And 2, all the surgeons, nurses, and other staffs in the operating room were wearing tertiary protective clothing. 3, most of the pregnant women delivered their infant by C-section, only one by vaginal delivery. 4, a neonatal transport team specialized in infection control performed to transfer the baby to the NICU. And for the third one, if the infant may get infected postnatally, especially during closely contact with the patients. In our hospital, we following the 5 rules. First, the mother and newborns needed to be isolated separately until both are cleared. And in the neonatal, in our NICU, level 2 protective clothing for all medical staffs were required. 3, all the neonates were fed with formula because initially we don't have any evidence to show that the breast milk is clear of the virus. So we dare not to feed the baby with breast milk. We only feed the neonates with formula. And now with the evidence coming out that we don't find any virus in the breast milk, maybe now we can change our rule. And 4, monitoring the baby, including the vital sign, oxygen saturation, blood glucose, intestinal mortality, and neonatal jaundice, just as normal neonates. 5, the medical and other equipment for these neonates were designated and not shared with other patients. So because we know that it is unavoidable to prevent the infection during delivery or postnatally. When we retrieve from the PubMed, we can find that there are at least 4 articles regarding to the late onset of SARS-CoV-2 infection in neonates. And the average onset of the disease is from 15 days to 27 days after birth. And the first sign of the first manifestation of the disease is varies. Some fever as the first manifestation, and some of them is a clinical signs of sepsis picture, and one case with gastrointestinal symptoms as the first manifestation. And although we know that mother-infant separation have great psychological influence on both mothers and babies, but according to our observation, the most efficient way to prevent infection in neonates is to separate the neonates from infected mothers and caregivers. So that's why until now, more than 40 cases born in our hospital and all the baby is born to COVID-19 mothers, but there's 0 neonatal infection rate in our hospital. So summary for what we already know, and the SARS-CoV-2 PCR test, we think is the golden standard. So if only we find the live virus from the neonates, we can show the true vertical transmission. Only elevated IgM only once cannot make the diagnosis. And the intrauterine vertical transmission is unlikely possible happened if the mother infected during the late pregnancy. And the infection during delivery and postnatally are unavoidable. So isolation the infant with infected mothers and other caregivers is the most efficient way, according to our observation. And we think the breast milk is good for the baby, but we are still dare not to use it. But I think pumping the breast and feed the baby with breast milk may be a better option for the neonates. And what do we need to explore in the future? 1, we should do more follow-up study. And only one elevated IgM cannot make that diagnosis, but continuous monitoring the specific antibodies may be helpful to verify the intrauterine transmission. Two, more evidence. We need more evidence of SARS-CoV-2, especially we should test the live virus at different stages of the breast milk, feces, and other samples from the neonates. And three, as I mentioned before, the maternal viral charge or timing of SARS-CoV-2 infection may influence the transmission. Now we still lack of data to support the intrauterine transmission if the mother infected during the early and middle stage of pregnancy. And that's my presentation. Thank you, everyone.
Thank you very much, Dr. Rong Zhihui. Now we're going to proceed to the dialogue session. And on the dialogue session, we have Professor Dr. Adriana. Professor Adriana is a professor and chief division of maternal fetal medicine, director of maternal fetal medicine fellowship program, Department of OBGYN, and medical director, prenatal diagnosis of Northern California, and chief of obstetrics at the University of California, Davis Health. And then we also have Professor Feng. Professor Feng Ling has worked as the head of obstetrics department at Tongji Hospital. And she participated in the creation of Tongji Hospital guidance of diagnosis and treatment of COVID-19 in pregnant women and neonates. At the beginning of COVID-19 in Wuhan, she is the chief editor of Obstetric Protection Manual for COVID-19 and People's Medical Publishing House publication, and 2 papers about the prognosis and prenatal diagnosis of the pregnant patients with COVID-19 have been published on the Lancet Infectious Disease. So let's welcome also Dr. Chen Ling. Dr. Chen Ling has worked as the head of neonatal ICU at Tongji Hospital, and she participated in the creation of Tongji Hospital guidance of diagnosis and treatment of COVID-19 in pregnant women and neonates at the beginning of the COVID-19 pandemic in Wuhan. So let's welcome all 3 of them, and let's start the dialogue session.
Thank you, Tom. This is Herman Hadriana from UC Davis Health. Thank you for the presentation, Dr. Liu, Dr. Rong, and thank you for sharing your experiences in Wuhan. The first question I have is really looking back at your experiences, and what was the first signs that you realized you were dealing with a novel viral infection in pregnancy and just not the regular viral infection that's fairly common?
So if I may translate this question, 这个问题呢，就是说，照顾孕妇新冠病毒感染的时候呢，他们的首先出现的症状会是什么？Dr. Feng 教授，if you may answer this question， 请回答。
您可以把你的手机打开，你看不见你的头像，你讲话的时候。
OK， 对不起。
Okay.
请。
Hello, everyone. I'm the Dr. Feng. 这个问题呢，就是首先发出的症状就是发热、咳嗽等呼吸道症状和全身乏力。Okay.
So the most immediate symptoms we see is fever and fatigue. That's the initial presentation of these patients.
I guess my second question is, pneumonia is the most common morbid non-obstetric infection in pregnancy. Was this a common observation in the first outbreak as you were watching these patients?
Yes. This question is answered is the yes.
Okay.
Okay.
And Dr. Hadriana, your next question.
Sure. And so one of the things that I've noticed on the slides is that the extensive personal protective equipment that you guys were using. I was wondering if there was a difference between vaginal delivery and cesarean section in your usage of PPE.
OK， 这个问题呢，就是说在阴道分娩和剖腹生产上，这个个人的防范措施呢，有哪些不同呢？
Okay, is it my PPT? 对于这个问题呢，我的回答是这样的：对于确诊或疑似的 COVID-19 的这个孕妇是3级防护。第二个呢，就是如果是急诊、产科重症来不及做一些确诊性的诊断的这些病人，我们也是3级防护。其他的非 COVID-19 的这些孕妇，我们就普通的这个防护条件，普通手术的这个常规进行就可以了。谢谢。
Okay, so my answer to this is for those with diagnosed confirmed COVID-19 cases, it's level 3 protection, and for those who presented with emergency and at presentation is also level 3, and for the rest is the regular protection.
Okay. 对于3级防护呢，我这里有一个一个要求，3级防护就包括医用防护口罩、护目镜或面屏、一次性帽子、防护服、隔离服衣、这个鞋套和靴子。对于这个接产过程中或者手术过程中，由于羊水和血液的这个喷溅，护目镜和面屏和长靴是很重要的。那么整个的防护呢，应该在贯穿这整个的全过程。这些产妇呢，就必须要全程佩戴这个外科口罩。Thank you.
So my explanation for the 3rd level protection includes mask, goggles, face shields, and disposable hat. And I think you guys can see this slides right here. So it explains the different protection levels and also at different conditions. So given the amniotic fluid and blood splatter during the labor and delivery process, goggles and face shields and waterproofing boots are important protection.
Okay. 可能大家还感兴趣的就是那个分娩时机，就像这样的一个 COVID-19 的这些孕妇，她什么时候分娩最好？我们呢还是这样要求的，根据那个疾病的严重程度、孕周和胎儿的情况来综合的决断。对于小于34周的，那么我们如果是轻型或普通型的 COVID-19 的这些孕妇，我们如果没有其他的终止妊娠的指征，我们建议在严密的监测的情况下面延长孕周。目前上没有依据，需要提前终止妊娠。
OK， 冯教授，麻烦你停一下，让我念这个，把它念。So the timing of or stopping the pregnancy or termination of pregnancy should be taken into all factors into account, including the severity of the disease, gestational and fetal intrauterine condition. Before 34 weeks of gestation with mild or moderate infection and no other indication of termination or pregnancy. Prolonged gestation, weeks under strict monitoring and follow-up. There's no evidence of early termination of pregnancy. So the termination of pregnancy here, does that mean abortion or does that mean ending the pregnancy? 洪教授，你可以解释一下这个就是termination of pregnancy 是指早生产还是
等会儿我要还有 等会儿还有的，就什么样的是顺产，什么样的是剖宫产，还有
冯教授他们对 termination 的定义可能会比较倾向于就是那个终止。我们的意思，我想那个我们冯教授的 termination 的意思是终止。我觉得这个词汇可以我们稍微变更一下。termination.
So the termination of pregnancy here.
I guess we will finish the gestation.
Yeah.
OK.
我让冯教授先说完。
好。那么如果有下列情况呢，我们就需要终止妊娠。一个呢就是有产科指征需要提前终止妊娠的。第二个呢就是它合并这个 COVID-19 病情没有好转的。最后一个呢就是 COVID-19 它是重症或者危重型的，这些需要终止妊娠。OK.
Right. So the termination of pregnancy, their obstetric indication. For mother with severe or critical condition, of course, there's early termination of pregnancy must be considered to protect the mother's safety. And for women diagnosed with COVID-19, termination of pregnancy, if the condition do not improve after treatment. So the next question, Dr. Hedriana.
Sure. My next question is
method. 就是这个分娩方式，因为刚刚都 termination 可能大家有疑问，对于分娩方式是这样的，我们建议放宽剖宫产指征。如果这个新冠是轻型普通型的，又进入产程的，我们就是在这个阴道分娩，经阴道分娩。那么其他的我们还是建议 section。那么为什么呢？它有3个理由。第一个呢就是避免病情加重。第二个呢就是有利于感染的这个防控。第三个呢就是中转的时候有利于更好的这个感控到位，使这个手术人员和医务人员这个在病毒感染的扩散的风险缩小到最低。Thank you.
Okay, so delivery of pregnant women with confirmed COVID-19. We should go through C-section. That's the preferred delivery method, and avoid aggravation of the disease and decrease the resistance due to physical exhaustion during labor. And it also benefits the infection control. And also in the case of transition to emergency cesarean section, infection control measures are difficult to be adopted quickly and effectively, and increasing the risk of spreading the virus and the medical staff getting infected. So these are the indications.
Okay. The next question.
All right. Well, my next question, that was quite interesting, Dr. Feng. Thank you. My next question is really revolves around testing. It's very controversial in the United States right now whether all patients that are admitted in obstetrics should be universally tested. I was wondering if you employ universal testing in Wuhan, one, and then second, was rapid testing available and what was your turnaround time? And I'll follow up with the next question after that.
OK， 这个问题就是说，在了解这个产后的可能的问题呢，在武汉是不是有这做排检的呢？那你们是不是有在所有入院的产妇呢都做了这个排检？
对，我们现在对所有住院的产妇都要进行4项的一个检查。第一个就是这个小常规，第二个就是 PCR， 就是核酸检测，第三个就是CT scan， 再就是 IgG、IgM 的这个检测。
Okay, we have yes, we have this test available. The first one is the PCR testing, and then the IgG, IgM testing, another one is the regular 对不起，我刚才没听好你的第一个是什么？
第一个就是血常规 blood
cell count。
哦 ，cell count 对，就是那个这一般的验血的这个 cell count。Okay, so the first one is the cell count, and then your PCR testing and the IgM testing.
So to follow up with that question, I wanted to know, in your opinion, what the role is of the COVID-19 PCR relative to the IgM and IgG in terms of timeline.
OK， 这个问题呢，就是说，在这个新冠病毒在这个PCR 和抗体 IgG、IgM 在时间上的关系是如何？
对，我昨天又正好又核实了一下，我们这个时间又提前了。昨天说是4个小时到6个小时，然后我们现在就是 IgG、IgM 的时间最快的是35分钟。那个核酸检测呢是3个小时就可以发报告。
Okay, so we have updated our data. Previously were 6 hours, and now we can do in 35 minutes, and the PCR turnaround time is about 3 hours.
Okay.
And the next question.
The next question.
I think that, yes, actually that was my prior question, the one that you have on the screen. The succeeding question was about the IgG and IgM. I think that's your next slide, Dr. Feng.
Okay.
Is the IgG, IgM in the term of the terminal? Okay. 这个图呢，我就把它放大，因为比较小。这个就是 IgG、IgM 在 COVID-19 这个里面的一些报告，就是分9大类，一个就是核酸阴性的，就这么多的排列组合。那么这些核酸阳性的就有4大类。那么因为时间的关系，我想就干脆就直接翻译了，谢谢。
Okay, so in this pictures, you can see that there are 2 different categories. One is the nucleic acid test negative, and the other one is nucleic acid test positive. In the nucleic acid test negative category, you have IgM negative and IgG negative, where this indicates an incubation period, which needs to ask for contact history and previous prior exposure history within 14 days. And then you have IgM positive and IgG negative. This indicates an acute phase of infection, and the nucleic acid result is false negative. And it also recommends us to repeat our CT scan and also nucleic acid testing. Where the IgM result is false positive. And then you also have IgM weakly positive and IgG negative. This indicates that the infection is in the early stage and the viral load is low, which has not produced IgG just yet. And low-risk patient may have interference by heterophile antibody or rheumatoid antibody interference. And then you have IgM negative, IgG positive. This indicates prior infection and the virus has been cleared. The patient is in the recovery period or has already recovered, and the IgG can exist for quite a while. The last of this category is both IgG and IgM are positive. It indicates recent infection and the virus has been cleared. The patient is in the recovery period and the IgM has not disappeared yet. And or the nucleic acid result is in the false negative and patient is infected and needs to repeat nucleic acid test again. In the nucleic acid test positive category, you have a negative IgM with a negative IgG. Of course, during this infection window period, no antibodies have been produced in the body, and or there's also a low immunity of the patient, and the patient is unable to mount antibody production. And in the nucleic acid positive with positive IgM and negative IgG, in the early stage of the infection, the IgM is produced about 3 to 5 days after symptoms appear. And with the negative IgM and positive IgG, in the middle or late stage of the infection, the virus has not been cleared or relapsed, or there's reinfection. And lastly, of course, with both positive IgM and IgG, is active infection. So the next question.
Yeah, my next question is, do you have information with regards to the clearance of COVID-19 RNA in maternal blood? Or is there a possibility that you may also find it in amniotic fluid?
OK， 这个问题就是说，有没有任何迹象显示这个COVID 这个新冠病毒的这个 RNA 呢，在母体里面清除，或者在这个羊水里面消除
？OK， 就是母亲血液里头这个，尤其是孕妇母亲血液里头的 RNA 的清除率几乎能够达到100%，大部分时间就是消失的时间是2到7天，羊水里头是没有的。
Okay. It presence in the amniotic fluid and maternal blood. It takes about 2 to 7 days in the maternal blood, but in the amniotic fluid there is none. Okay, then the next question.
My next question is really talking about vertical transmission. I know you have talked about vertical transmission. Dr. Rong presented that. But would you consider the probability of a horizontal transmission during the time of delivery?
我的下一个问题就是关于这个就是贫水感染，就是母亲传染婴儿的这个几率你在这个生产过程中是否考虑说这个母亲传染婴儿的这个可能性呢？
对，我们也做了检测，流了羊水、脐带血和胎盘。那么这些检测呢，目前我们这个都是阴性的。那么我们的经验就是尽早断脐，尽量的把孩子移出这个母亲的环境，到另外一个房间的新生儿复苏台上面去处理。
OK，
基本上都是没有传染的，没有感染的。
Okay, so we have tested, amniotic fluid, cord blood, and placenta, and the goal is to remove the baby as soon as possible from the mother. So far we have not had a positive infection.
My next question is that given your experience of the 19 neonates that you just reported with probably no evidence of vertical transmission, which seems to be consistent with the systematic review from De La Gata recently, is there argument in trying to postpone delivery in mothers who are COVID-19 and are not at term?
And what's the thing that you said in the end? I'm sorry, I can't hear you.
Postponement of delivery in mothers who are not close to term, who are premature.
Okay. 对于你这19宗病例的经历呢，和最近这个意大利的57起这个讨论的结果呢，有没有关于这个垂直感染的病例呢？是不是意味着可以将有新冠病毒感染的母亲呢，尽可能呢把他们的分娩期呢 尽量推后这个做法？
在我们这里有几例就是中孕的这些轻型和普通型，也就是症状比较轻的，在治疗了一段时间以后，它就这个核酸就转阴了，然后一直到妊娠晚期才这个分娩后的孩子也是都是阴性的。
Okay, we have a few milder cases of pregnancy, cases with pregnancy with milder symptoms and light symptoms, and after treatment, they tend to turn negative. Okay, 继续。
OK， 那么像这种病例不多，大部分都是晚期妊娠的。晚期妊娠的刚刚也是的，如果是症状不是很重，我们也是维持妊娠到这个尽量到足月。但是我们的经验是，如果是晚期妊娠0到预产期的，剖宫产还是比自然分娩要好。这个分娩方式的选择。
Okay. So we don't have much of the problem with the a few cases we actually proceed to like late pregnancy. Some of these cases I'm sorry, 你再讲多一遍可以吗？
就是在临近预产期的，如果选择分娩方式还是 section 要比这个阴道分娩要好。
So for those who are close to your term, we still prefer cesarean section because the risk of infection is less.
所以我们这里整个湖北都没有出现重型的和微重型的这些孕产妇，一例也没有。
So that's why in our Hubei province we have not had a heavy or severely infected case so far.
My next question is actually for Dr. Rong. What are the criteria when a neonate from your NICU is cleared for discharge?
Go ahead.
Okay. So in our hospital, if the neonates have no clinical signs of infection like fever or dyspnea, and also we check the baby's throat swab PCR test negative at least twice within 24 hours of interval, we discharge the baby home, but making sure that the caregivers are clear of the virus. Yeah, that's it.
Thank you, Dr. Wang.
Thank you. And so, Dr. Feng, my last question is, what would be your best advice for pregnant women who have COVID-19 infection in the first, second, or third trimester?
这个问题呢，就是说，您对分别在第1周期、第2周期和第3周期，新冠病毒感染的孕妇的议案有哪些呢？
好的，谢谢。那么对于第1周期呢，目前没有什么证据证明它这个早孕的时候会传播给孩子，所以这第1周期的这个孩子的去向呢，由这个孕妇自己决定。如果她要终止，我们就帮她终止。
Okay, 在这里听一下。So in the first trimester, there's no major evidence of transmitting to the baby. So this decision is left to the pregnant mother. If she want to terminate the pregnancy, then we let her, terminate the pregnancy. Okay.
第2周期和第3周期的还是尽量的，如果是轻型和普通型的，还是让她继续维持妊娠到晚期，到胎儿能够存活的孕周。
Okay, so for the second and third trimester, if there is light symptoms, then we let the pregnancy carry on to term as much as possible.
但如果是重症的，不管是哪个周期，都要终止妊娠。
And if it were a severe infection, regardless of which trimester, we would terminate the pregnancy.
Okay.
That's all my questions.
Thank you, Dr. Adriana. Thank you, Professor Feng.
So this is Tom Gong. So we'll start the Q&A. Please change your Zoom name. You can go to your name. Yeah, Dr. Zhang, Dr. Teo, I will take over, okay?
Okay, thank you.
So you can change your screen name, right click to be your name and your country. And myself, and I will call on you and I will unmute you. At the same time, Dr. Lee will also ask some questions you asked, during the registration. Hold on, let me get Dr. RJ from India. Okay, let me unmute him. Okay, what's his name? RJ, where's RJ? Let me find it. Okay. Dr. RJ Rakesh Verma from India, are you there?
Yeah, I'm here. Can you hear me?
Yes, we are. Can you share your experience in India, what's going on in India, and then ask a question? We're very curious on not much, we can read from newspaper.
Well, I don't have a first-hand experience of dealing with a COVID pregnant woman and infants, but in the earlier stages of the pandemic, we don't have much testing equipment and we treated all the patients as COVID positive and we took all the precautions. And we made the OTs ready for the patient and most of them were emergency LSES. And other parts of my country, I have heard from my friends that they have been dealing with the patients quite some time, but there haven't been much serious COVID patients among the pregnant women. And as far as I know, what would you like to know about the scenarios here?
That's fine, whatever you want to share. Do you have any question for the doctors in Wuhan?
Yeah, I would like to know what therapeutic approaches did you use for the pregnant women there? Have you used the hydroxychloroquine or any other antiviral drugs? And what about usage of steroids? Have you given the any steroids if you have to terminate the pregnancy earlier to prevent ARDS in the infants to stimulate? Usually we give steroids to stimulate surfactant production in the infants before 34 weeks of pregnancy if you're going to terminate the pregnancy. So is there any input in that aspect? I would like to know.
李医生，麻烦把这个问题翻成汉语。
好的，他的问题是这样子，他说你们有没有用什么药治疗孕妇？是不是还还有呢，就是说，在你不得不终止妊娠早期就是说早产的时候，要不要用那个steroids？因为要防止 baby 有 ARDS， 所以两个问题，一个孕妇的治疗，一个 baby 的治疗。呀，
好的，我们在孕期的时候呢，抗病毒药在征得孕妇同意的情况下面是可以用的。
你用的是什么？
有阿克洛尔，这个还有一些这个就干扰素的一个喷雾剂，有时候会用。我们还有我们医院自己的中药，那个金叶败毒虫剂，这个是用的。
Yeah，
麻烦李医生翻译一下。
Yeah, so the medicine, they will ask mother for permission to use it, and they use Chinese herb medicine. They also use interferon spray, spray to the nose or spray to the mouth.
Okay,
spray 鼻子还是嘴巴？那个 interferon
咽部
，the spray to the mouth.
嘴巴。
Yeah, and then I don't think they ever use hydrochloroquine. Yeah, 氯喹没用过啊？
没有。
They are not using a hydrochloroquine at all. They never use that. Yeah.
产后呢，我们就可以用一些利克滋，就是原来抗艾滋病的那一类药。 产后生完了以后会用，就是其他的抗病毒药。
They use other antivirus medicine. That medicine was used for HIV patient before.
我们中文叫利克兹，
我不知道英文叫什么，利克兹。
好
，Who
那么
knows
对于这个促胎肺成熟的药，我们是用的。那个按照产科的要求，34周以前我们是用这个促胎肺成熟防止 RDS 的，这个必须。
So for the pregnancy that before 34 week, they will use steroids for the baby to prevent ARDS. They do use that. Yes.
Okay.
Did that answer your question, Dr. Ake? Okay, we move on to the next one. Dr. Mulat at first from Ethiopia. Are you there? Hello? Dr. Mulat from Ethiopia at first. Okay, I'm going to the next one. I'm going to lecture Dr. Mazza from Ireland. Okay, I'm going to unmute you. Okay, Dr. Mazza, let me search.
Yes, I am available from Ethiopia.
Okay, can you share your experience and ask your question?
Thank you so much for your presentation. But in our country, the case of this COVID virus is quite low. It is a gradual increasing, and it is only some 133 cases in our country. So we don't. So far, there is no reported case of pregnant and delivered mother.
他说 ，Should I translate?
No, 不用，他没有问题就不用翻译。Do you have a question for the doctors in Wuhan?
Yes, I have a few questions, like on issue of fetal monitoring, other than CTG, like in less developed countries, often we use fetoscopic monitoring. So what is the place of monitoring the fetal heartbeat with fetoscope? The risk of monitoring with fetoscope to transmission of the virus for the attendant. And the other question might be, is there any study of risk of transmission from laboring mother to the provider, as there is a risk of exhalation of the virus during high risk of transmission of the virus during labor. It is assumed to be aerosolization during labor. And also, do you have any experience on the laboratory finding of COVID disease versus preeclampsia? Because they might get a confusion between lab result of COVID infected mothers and the laboratory abnormalities of preeclampsia. Thank you so much.
一共3个问题啊。第一个问题，他问的是，在他们这种条件不大好的国家，怎么 monitor 这个 feeder baby？ 如果妈妈是 positive 的话，你怎么那个？ Dr. Feng，你可以回答这个问题吗 ？Fetal monitoring 就是那个胎儿在妈妈胎内的时候，你们怎么监护胎儿？
对，
情况
最简单的就是胎动，然后就听胎心。OK， 首先是胎动，第二就听胎心，如果有的话就有胎心监护。最后就是超声检查。
Ultrasound. So her suggestion for fetal monitoring is monitor the fetal movement, and then also the fetal heart rate, and then also of course if you have ultrasound, you should do prenatal ultrasound to monitor fetus. Yeah. 第二个问题，他是说，那个你们有没有发生，就是说在产程的过程中，那个传染给 baby 的或者妈妈的传染给其他你们的医生啊，医生护士这个有吗？
没有。我们这么长时间，我们整个同济医院里头这个产科没有发生因为这样的阳性的病人而造成其他的院内感染，也没有医务人员感染。
So her question to your question about whether there's a transmission to the providers during the labor and delivery, and her question is for in their hospital is zero transmission to the providers, and they have none so far. And third question, 他是说preeclampsia 中文怎么翻译？就是那个产前癫痫。他说对这种对这种病人，你们有没有什么实验室的，就是 lab 的monitor 有没有什么特殊的血的检查，实验室的检查这一类的病人？
就是子痫，就是癫痫，就是如果是抽搐，它有好多种，跟产科有关的，就是高血压造成的。
Yes, yeah， 它就是这意思，它就是高血压
造成的，就是实验室的检测呢有一些预测的这些，但预测的临床上面它的预测效果都不是很好。所以我们还是以控制血压为主要的一个治疗的一个手段。控制血压，然后尽早的终止妊娠，就这2条。终止妊娠是王道，控制血压是一直都要进行的措施。
Okay. So her question to preeclampsia, she say most of the lab tests has really poor prediction to which woman gonna have seizure or not. And so the main treatment for them is control hypertension, consistently control hypertension, and also early delivery if a woman thinks to have a problem. Yeah.
Okay.
That's it. We can go to next. Or we're done with the questions.
Okay.
Tom, are you going to ask another question? Oh, we cannot hear Tom. So,
Tom, are you there?
Tom, are you there?
Ireland. Yes.
Ireland.
Yeah, I'm here. So can you share your experience and then ask your question, please?
Oh yes, my name is Francisco Mesa, consultant neonatologist in Ireland. Particularly, we have 4 third-level ICUs around the country, 3 in the Dublin city. In my maternity hospital, we have at the moment 2 babies, but more with COVID-19. Both babies are okay. And my question, particularly for the Dr. Rong, is do you follow your babies in your own hospital or you refer for another hospital?
Excuse me, can you repeat the question because it seems cut off?
Sorry.
Your
My question
voice cut off.
Or Dr. Rong.
Dr. Rong. Dr. Rong. Yeah.
Yes, can you repeat your question? I'm sorry.
Yeah, is if you follow your babies in your own hospital at 2 weeks or 6 weeks time, or you refer these babies to another hospital when the babies were discharged home?
Okay, so your question is whether we discharge our baby just right after go home, or we refer our high-risk baby to another hospital?
Yes.
Okay. Actually, our hospital is the hospital designated for COVID-19 mothers and babies. So we just transferred the baby from the delivery room to our NICU, and we observed the infants for like 2 weeks. If the baby is clear of any virus infection, we discharge the baby directly home. Yeah.
Okay.
Does that answer your question?
No, it's okay. Thank you very much.
Thank you.
Dr. Li, can you ask some questions people ask in the registration?
Yeah, sure. I have some questions people ask on Zoom. They submit those questions, and Anna Andreska from Romania, and so her question is, do mother pass on COVID-19 antibody to the baby, which means is the mother have IgG antibody pass from the placenta to the baby? Do we know about that? Who gonna answer that question?
翻成汉语，把问题翻成汉语。
Yeah， 他说妈妈的 IgG antibody 是会不会 pass 到baby 身上 ，newborn baby？ Dr. Rong or Dr. Chen？
陈主任，你看您那儿打开麦克风有声音吗？
我听得到你的，
Okay, so because there's some problem in Dr. Chen's audio or video, so I will answer this question on behalf of Dr. Chen. And the answer for does mother pass the SARS-CoV-2 antibodies from mother to infants? The answer is yes, because we know that IgG antibody, the molecular of IgG, they can transfer from the mother to the baby, and but if we want to make a diagnosis, we must closely follow up, monitor the IgG and IgM as well.
Okay, so shall I go to the second question? And so there is Karen Ling from New Jersey. She is asking the question, say, do you give prophylactic treatment to baby with COVID-infected mother?
Okay,
你有没有预防性的治疗？如果妈妈是阳性，你会不会做预防性的治疗 to newborn? Yeah.
Okay. So for the baby born to COVID-19 positive mother, we don't give any treatment on this baby. We only isolate the baby from the infected mother and just closely observe the baby have any signs of infection. So we don't use any antivirus treatment on the babies. That's it.
Okay, great. Thank you.
We have Dr. Li. We have a question from audience. Dr. Grigor from Macedonia. Are you there?
Yes.
Okay, can you turn on your video? Yeah. Can you just show living experience in your country and then ask your question. Please turn on your video if you can. Also turn unmute. Your mic is muted. Hold on. Let me. Okay, Dr. Gregor, you can speak.
Okay, thank you very much. I was listening to all of your discussions and to the lectures, and I find them very interesting and very much similar to what we are doing actually in Macedonia, because our university clinic is a referral center for the suspected and for confirmed COVID cases. And we don't have too much experience, but we have organized, we have done some good medical engineering in the manner of accepting the pregnant women to a special, can you hear me?
Yes.
Yeah.
Yes, we can hear you.
Yeah, to a special entrance, to a special point of entrance, even though they are suspected or confirmed, because we have some of the cities in Macedonia, actually in one of them there was a complete quarantine, and in the two of the others there was a big number of COVID positive people actually, and so one of the hospitals actually didn't provide correct measures for the personnel in the hospital, in the gynecological and obstetric department, and they have almost 40% of the employees were positive, tested positive. So we accept all the patients from that hospital as well. And so far we had 4 patients who were positive and who delivered. And unfortunately, we have 1 who delivered spontaneously and 3 by cesarean sections. And unfortunately, 1 of them developed a difficult, very severe disease of the lungs. And I don't know, and I haven't heard from anybody yet, but actually this patient, she was a secondipara, it was a second cesarean section, and she died. She had a very worsening condition on the 8th date, and on the 9th date after the cesarean section, she died, even though she was very young, 27 years old. But the babies are all negative. Babies are all negative. And we have the same attitude, and that would be my question actually, because in general, nobody supports the corticosteroids for fetal maturation, and we should expect and treat the patient until she gets to term and to the, let's say, more secure environment for the baby, at least after 34th gestational weeks. But do we have some scientific data supporting this, or this is just recommendation that we have to follow? Let's say if there is a specific condition, we shouldn't try and give corticosteroids, or we can maybe give them. And in general, the interim recommendation of our Association of Gynecologists and Obstetricians is that we should try to deliver the women as vaginally if possible, if it's in a visible period of 3 to 4 hours. If not, all of the patients are actually going straight to the cesarean section. So what's your opinion again about that? So that will be the second question, let's say.
OK， 他有2个问题，一个问题就是34周以前的孩子，你们有没有任何这个 scientific data 说用 steroids are better？ 有没有什么特殊的情况你是不能用 steroids 的？就是这个34周以前的这种孩子。然后第2个问题很像是产科的问题，就是说他们国家还是主张要那个阴道分娩，但是他说你们的主张是要这个，为什么？这个其实我们前头讲过了，但是他问了这个问题。 是阴道分娩和那个剖腹产这个指证是怎样的 ？Yeah，Dr. Rong， 你先回答那个。
这两个问题都是产科的。关于
Dr. Feng，
can you chime in?
Sure. Chime into the steroid question or chime into another question?
So whatever. Yeah.
Oh,
steroid
okay.
question.
So here, there hasn't been any literature that has been published, but there are anecdotal reports on our calls where women after 34 weeks, especially if they're critically ill with COVID-19, the steroids given can actually increase the likelihood of the duration that they are in intensive care unit or the ventilator. We still give steroids before 34 weeks, and our society recommends that they should be given on a case-by-case basis.
Okay, do you want to talk about the second question, the vaginal delivery versus C-section?
Okay.
Yes.
Yeah.
I mean, I definitely, I mean, the environment in Wuhan is very different from what we have here in the US. So as of now, we encourage everyone to have a vaginal delivery as much as possible, especially if the infection is mild to moderate and not critical. If it's critical, then most of the time they end up being delivered by cesarean section just because you want these women to have ventilatory support. So the sooner they get delivered, the better. But for asymptomatic, mild or moderate infection, I think vaginal delivery as in general is still the recommendation here in the US.
Thank you. Tom, next question.
Dr. Semenyak, you raised your hand. Dr. Semenyak, yeah, can you turn on your video? We can't see you. Turn on your video, please. You can. Go ahead, Dr. Semenyak. You can ask your questions. 李医生，你继续问你的问题。
Okay.
Let's move on.
So let me start asking questions that people submit ahead of time. Let me see. So there is a question from Carla Bridges from Huntington Woods in United States. She asks, is there any updated information on antibodies from breast milk as being immune protective to neonates born to COVID-19 positive mother? Should critical ill mothers be pushed to provide milk right away? Dr. Rong.
Okay, so for this question, so we, in our hospital, we do not check the antibody in the breast milk yet. And also, according to my knowledge, I didn't find any literature regarding to the antibody in the breast milk. But we already know there's no virus in the breast milk. So I think pumping the breast and feed the baby with breast milk is a good option for the baby. But I dare not to say whether we should do skin to skin care for the baby, because although we don't know, we know that we don't find any virus in the skin, in the mother's skin. But if the mother do kangaroo care, it is unavoidable if the mother uses his hand to touch her nose and contaminate the environment. We don't know, so we dare not to recommend for the skin to skin care or breast yeah. We just yeah.
陈主任，
哎，听到没？哦，有声音了，太好了。
你有补充的吗？
这个没有什么补充的，这刚才我们讨论过的这个问题。
Okay, so Dr. Lee, next question.
Okay. So what is most useful specific criteria to test a newborn? How do you know newborn is having a COVID infection? Yeah. Diagnosis criteria for newborn. Yeah.
翻成汉语，把问题翻成汉语。
Oh, Dr. Rong, 他们说治疗陈主任治疗新生儿诊断的那个指证是什么？如果你怎么确认一个小孩是得了 COVID-19？
你那个I think we 就是这个是 what are the specific criteria?
Criteria, yeah.
Okay. For the garden criteria of the COVID-19 is nuclear RT-PCR, nucleic acid RT-PCR. But till now in our NICU, we didn't detect any neonates with the positive nucleic acid RT-PCR. So I think this have many
听不到，什么都听不到。We cannot hear anything.
荣医生接着回答。荣医生，现在这个陈医生、陈主任这边有问题了。荣医生，麻烦回答这个问题。
Okay, so we still think that finding a live virus from the neonates can make the diagnosis, especially when we use the RT-PCR to find the virus. And for the antibody like IgM and IgG, we only once elevated of IgM cannot make the diagnosis. So we need to follow up the trend of the IgM change in the neonates and IgG as well. And until now, in our NICU, we admitted more than 40 cases, but we don't find any positive PCR from all the 40 neonates. Yeah, that's the
so next question here is ask how often you test PCR. What is the timing you do PCR? And antibody too. What the interval? 就是说你什么时候开始做这个检查？你多经常做？要做几次？隔几天做几次？这个问题。
So we do the first time we do PCR and antibodies right after birth on day 0. And the second is we do the PCR on 24 hours after age. Usually we do 2 times of PCR with 24 hours interval.
How long you follow up with IgG?
According to our observation, the increased IgM decreased to down to normal level is around 14 to 28 days after birth. But for IgG, it is even longer stayed in the neonates. Yeah.
Okay, thank you.
Go on, Dr. Lee.
Okay, go on more. Okay. So also, Haiyi Salazar from Mexico City, she asked, neonates with COVID-19, how many days should be watched, or any those unstable should be hospitalized?
Okay, so initially, because we are not very we don't get much information about this virus. So initially in our NICU, the policy is we isolated the neonates in the NICU for 14 days, just according to the older patient, because the incubation period is around 14 days. But now we have more and more evidence that we already know there's very low incidence rate in the neonates. Regarding to the vertical transmission, the rate is really low. So now we are shortening the isolation time in hospital. Usually we check twice PCR with 24-hour interval. If the PCR all negative, we discharge the baby home, and just to make sure that all the caregivers are clear of the virus.
Thank you. And last question I have here, and that is a question from Arturo Villa from Monterrey, Mexico. His question is actually to OB doctor, is how many days you do a screening, a PCR screening for pregnant women before they go to labor and delivery? How many days before you want to screening for it? So 他的问题是给你们妇产科的，他的意思说，他们要那个如果是足月的妇女，你在什么时候几天前，在她进入产房之前会做 PCR 的检查？ Dr. Feng？
好 ，OK， 这个我们住院的时候，全部要查，然后住院的第3天再复查 PCR 和 IgG、IgM， 如果都阴性的，我们就按照一般的孕产妇来处理；如果是阳性的，我们就到我们另外一个定点医院去处理了。所以他到产房的时候肯定是已经复查过的了。如果是阳性的，就按照三级防护来进行分娩。
Okay. Yeah. So in Wuhan, they right now doing universal screening, and their turnover time is short. But like they mentioned, so they usually just do it when they admit to the hospital. They will do one, and then after 3 days, they will do second one. If they are positive, they will send into the isolation room, negative pressure room for those. And then they will do level 3 protection.
Do you want me to answer that too, Tom?
Yeah, please. Yeah.
So for elective cases for labor and delivery, we screen them 48 hours before they get admitted. But otherwise, all admissions, as they come in, they're universally screened. We use RT-PCR. If they get screened at the time in triage, we get the results back within 8 to 12 hours.
Okay, that's really useful. So the answer is to do 48 hours before admission if we know they are coming. Yeah. So my question. We have more doctor there want to ask questions.
Okay, I think that's all for today. And hello, Dr. Lee, can you hear me?
Yes.
Okay, thanks everyone for attending. And as I mentioned earlier, we will email the presentation to everyone, and the videos will be available to the YouTube a couple days later. Okay, thanks everyone. I'm muting everyone, and you can show your video if you want, but you can exit the conference.
Bye-bye.
Bye.
Thank you.
Bye.
Thank you.
Thank you 啊
A 班第一轮就淘汰了，是吗？
拜拜。
，bye。
Fine voice.
拍一张照片。
Bye. Sampai selesai. Bye. Bye. Ganto. Bye. Ganto. Ganto. Esta frase completa. Bye. La Ling Chen es la jefa de obstetricia que ha hecho la guía ya en habla chino.
那个粉医生，他那个印度的 experience 很像我们蛮像，但是英文都很好，没事。
Long it
Sí,
takes
no
to
sé.
condense the graph.
那真的第一季我完全没记住，我记得他是下一张传奇记得。
She went back a little bit. Once she said, right, done, resigned. Not going back. Once she didn't have anything, tell everybody, everybody doing it. A piece was just up in the air.
Where are you from?
Talking to Brad. I didn't even realize that so much things is going on. So even Dr. Singh is like,
哇，那很强了。
every
Que dice que la Ling Chen es jefa de la ICI neonatal del departamento del Tongji. Mira, el Linto, el chino que estaba haciendo de moderador, es neonatólogo.
哦哟，
It's real thing. It's real politics.
唐，你看到多少人吗？参加你们的大概1000多个人，1000人以上。
没有那么多。
哦
哟，
测的有400多，半人上来。
Yes， 但是你们的那个我也来听过。
你看这个，你说测5，他们都喜欢穿那个就比较显腿，然后想好看。
对，肯定比高跟好一条。
And instead of just saying no, that's not what happened, I'm sure they call. Right, you will call Dukran. Dukran will be, she's in the department, and then she will call the consultant on phone. And then the consultant will keep doing it. And I'm like, listen, people in the waste council everybody every morning. Don't call me to ask, man. Tell the man that no.
Suryani from Indonesia, thanks for listening.
Don't take for it. We always act like we didn't do
Landers from Mexico.
I'm HOD. My parent calls me and said, you know, nobody tell me anything. I'd be like, well, I find that very hard because I know that every morning we are coming. So what did they tell you this morning? They always act like, I saw that out. So but what, yo? Always get me back. So you know, it takes one call.
Living, right?
Friends. Even though, and when you go to the notes, it's like every time they get review, you had like multiple counters, multiple everything, multiple things being answered. And you, when you go, oh no, doc, I good. Touch me.
Dr. Ikata Damayak, sorry, we didn't have the question. Yeah.
Is that right?
he's going to die in 2 minutes. Would you like to come back in? He was there. It was there.